Great. So as we mentioned last time, or not as we mentioned, but like last time I was interrupted because of some things, and now we're back. So we're just going to kind of continue where we were with the opioid lecture, and maybe, just maybe if we have time, we'll get on to the cannabinoid lecture. So just a quick recap on opioids. The opioid receptor in the brain, right, is a type of receptor that induces certain sensations when it's activated. Now, this particular receptor is primarily known for inducing analgesia, which is pain reduction and calming effects, and respiratory depression is a really major one from opioids. And this is the biggest danger that we see from opioids, is people not breathing as effectively as they need to sustain themselves effectively. Now, because of this analgesic effect of opioids, there's this interesting phenomenon that can happen through time called opiate-induced hyperalgesia, which is basically a hypersensitivity to pain following chronic administration of opioids. So this is not something you would expect, right? You would not expect a pain relief medication to have the kind of paradoxical effect of making people more sensitive to pain through time, but this can indeed happen. Now, again, the respiratory depression of opioids is the most dangerous side effect here, right? Because what can respiratory depression lead to? What are the consequences of having lowered breathing and respiration?
Hypoxia.
Thank you. Hypoxia. And what is hypoxia?
That's when you're not getting enough oxygen.
Exactly. And what are some symptoms of hypoxia?
One of them is, don't people start turning blue?
Yes, exactly. So especially your kind of peripheral extremities, so your fingertips, your toes, your nose, your lips might start turning blue. And further than this, if someone doesn't get enough oxygen to their body, your heart will stop eventually, right? Which can lead you to go into cardiac arrest. And if you're not breathing for 4 or more minutes, if you're not getting oxygen to the brain for 4 or more minutes, you start suffering brain damage. So this is why if someone goes into an opioid overdose, even if you administer naloxone to them or Narcan, which we'll come back to later a couple of times, you always need to call 911 anyway, because oftentimes you're not going to be quite as effective at administering CPR as first responders would be. You do not want to take the risk, even if this person might have woken up from the naloxone. Sometimes if an overdose is major, you might not have enough doses of naloxone to effectively reverse their overdose. You don't want this person to die. So you need to call 911 because they're way better at administering CPR than you are, most likely, in most cases. And then there's the risk of dependence or addiction. And again, these are two different things, and addiction is very complicated, and we're going to come back, like I've said before, in greater detail to it later. But it is true that opioids do hold a very high comparative risk of developing dependence and or addiction. And remember, these two things are not mutually exclusive. You can be dependent on a substance without necessarily being addicted to it, and vice versa. And we'll talk about why exactly that is and how you distinguish that a little bit later. So let's take a look back at the history of opioids, because again, this is a very hotly contested drug. We start out with the opium poppy, right? And the opium poppy is something that is predominantly found in Southeast Asia and the Middle East. And in, I think it was the 1700s. Oh, I should know this. The 1700s, I believe. This looks 1700s-ish to me. The Opium Wars took place. I feel really weird for not knowing what years this was. I'm pretty sure it was the 1700s. So Britain starts importing opium from India. They sell it to China, and then China's like, oh, fuck. Like, a lot of our people are really into opium right now and are actually developing problems from how into opium they are. So we're gonna not accept this import anymore. And then Britain's like, fuck you, let's fight. So they have a war, and then that war is over, and they're like, why don't we do it again? So they do it again. And that's the first and the second opium war. And the whole premise of this war was China being like, dude, this import is actually kind of damaging to us. And Britain was like, well, we run on a capitalist agenda, so we're gonna blow you up. Now, in the Civil War in America, opiates started getting introduced into this circulation for treating Civil War soldiers. And it became a standard of medicine during this period of time that totally revolutionized how we treated pain. How many of you have seen Pan's Labyrinth? Whoops. Pan's
Me.
Labyrinth. Ah, I just watched it last night with a friend of mine on Netflix party, and both of us, I just had forgotten how incredibly dark it was, and I was like, oh. But a part of Pan's Labyrinth, amazing movie, you should totally watch it if you can stomach it, it's great, is one of the revolutionaries, one of the rebels, a commie rebel in the Spanish Civil War in the 40s, I think it's set in 1944, has his leg amputated. And before he has his leg amputated, you see him chugging a bottle of wine or whiskey. I'm actually not sure which it is. And that was standard issue before this, you know, like if you were a war veteran or if you were someone that had been injured in combat, you might have had to just like chug a bunch of booze as your pre-amputation sedative, like Jesus Christ. So when morphine came around and we started distilling these opioids from the opium poppy, it really changed the way that medicine could function. And then, of course, because women never get away unscathed in the history of drugs, America was like, well, you guys are acting out because you're PMSing, so why don't we like sedate you with opium? So that became standard practice for a while. Meanwhile, in America, a little bit later, we have women that are being treated for obesity with meth. That's just like, you know, it's women. Like, you can do whatever you want. Obviously, it's fine. Now, going back to the 40s and the 50s, in the US, jazz was starting to become really popular in a way that totally changed. Again, I know I keep saying this. I read somewhere on the internet that they soaked tampons and stuff. Yes, tampons soaked in opium were a treatment for menstrual cramps. Seems actually like it might be kind of effective, but maybe with side effects. But the 40s and 50s, jazz started bubbling up in the United States, and it was predominantly Black musicians that, I mean, obviously, it was predominantly Black musicians because Black musicians started like all music, who were utilizing opium and heroin specifically as part of jazz. And there actually was this entire subculture that was created out of this community orientation around heroin and jazz, such that a new addiction treatment center opened up called the Narco Farm, where all the greatest jazz players ended up getting hospitalized. And this is actually something we'll come back to later when we start talking about counterculture after the spotlights, is this concept that you would actually want to go to the Narco Farm if you wanted to play with the greats, because they had the best jazz band ever at this addiction treatment facility. And then in the 70s, Janis Joplin died, and that really impacted the way that America viewed opium and opiates and heroin. And then after the Vietnam War, a staggering percentage of veterans would come back to the United States addicted to heroin and other opioid-like substances because of the opium poppy being so readily available there. Now, here's something that you guys might not have thought about. There are about 7 countries that consume approximately 77% of the world's morphine. That's a lot of the world's morphine that is being soaked up by the United States and several countries within Europe and Australia. Now, this is a really big problem because this map kind of shows you like what the morphine access is, and that's fucking really uncool, someone would say. Like, just check out this complete inequality in access to morphine, which is an essential medication for pain relief and for surgery. So there's actually like a huge issue right now with controlling access to morphine and to opium poppies, especially in light of wars and war victims and civilian casualties and who does and does not have access to these medications. Now, looking specifically at prescriptions, the dosages for these will all vary, the specific effects of them will all vary, but we're going to look at some of the most commonly used for recreational purposes, prescription opioids, predominantly Percocet, Vicodin, morphine, codeine. Now, there aren't really a lot of specific terms for these, just like for opioids as a category, like routes of administration wise and things like dope, which can be applied to a lot of different opioids. And I want to point out a discrepancy here, which is the generic drug. Now, I know that I've said this before, but in case you've forgotten, the generic version of a drug is the active component that you're buying that can be basically repackaged and sold under different names by a lot of different companies. So for instance, Percocet or OxyContin are two brand name versions of the generic ingredient, which is oxycodone. So when we're looking at drug names, it can get kind of confusing sometimes because you see, oh, OxyContin versus oxycodone, what's the difference? And the difference is that oxycodone is the primary active ingredient, and a company snatched it and was like, okay, we're going to package it in this way, in this dosage, with this color and this press and this binder, and we're going to call it OxyContin. And then Percocet, in the meantime, I'm pretty sure is acetaminophen, which is Tylenol, mixed with oxycodone. So that's how these different brand names can manifest themselves. So make sure that you look up the different generic drugs that are contained within brand name drugs, because that can tell you different preparations of the same thing. So in that line, there's morphine, which is sold under the brand name Duramorph, among others. Then there's Vicodin, there's hydrocodone, which is sold under the brand name Vicodin, and codeine, which is promethazine, which is, codeine. It's just always codeine for the most part. Now, usually when someone will pick up pills from a pharmacy for the intention of ingesting them, you might be like, well, they'll just eat them, right? Or it doesn't really sound that weird when you say eat pills. I think it makes sense. But most of the time, people will just assume that you get a pill from a pharmacy, you put it in your mouth, you swallow it, hopefully with water, because otherwise it hurts your esophagus. But most of the time, what people end up doing is crushing, I can't even see what I'm doing right now because you guys are on my corner, is crushing it, and then either mixing it with water solution in a spoon, heating it underneath, and then drawing that into a syringe and injecting it, or snorting the crushed powder. Can anyone think of a potential hazard of snorting a crushed pill? What might be an issue here?
Nasal cavity damage,
Yes. From what?
chunks of uncrushed pill, jagged little pieces.
Yes, yes.
Binders,
Binders. Exactly.
excipients.
Exactly. So a lot of the time there are other things contained, in fact, all the time there are other things contained in this pill that aren't necessarily the active ingredient. And you don't know how caustic those things are for your sinuses, right? Or you could eat it. That is the simplest way to do it. Doesn't take much preparation. Now, I'm sure that many of you are wondering about fentanyl. I have a lot of answers about fentanyl. This is a really hot button topic right now, obviously, and I can shed some light. So if you have questions about fentanyl, or you've heard something that you think might be a myth about fentanyl, please say so. We could talk about it. This is a lethal dose of heroin. It's a really small amount, don't get me wrong, like that is like only a little bit of a vial. It's like this much. This is the lethal dose of fentanyl. This is, if you really distill it, effectively a couple grains of sand. This is the lethal dose of carfentanil. Now, carfentanil is an opioid that is, I think that fentanyl is 50 times more powerful than heroin, and carfentanil is 100 times more powerful than fentanyl. Now, you don't really have to do the exact math to know that that is a really substantially powerful substance. This is the legitimate elephant tranquilizer. Like, this is the actual thing that's used to tranquilize elephants and other large mammals. Like, this is the only drug that we'll talk about where it's like, this is elephant tranquilizer, among other things, but it's so potent that it hasn't been approved for use in human medicine, and it's oftentimes used, or it's currently being advertised on the dark web as being a biological warfare or a chemical warfare weapon. Also, if you're not muted right now, could you please go ahead and mute yourselves? We can hear you breathing. Thank you. So carfentanil, super powerful, super fucking powerful. And we've actually seen for the first time, I've seen for the first time on the illicit market, a drugs data report of a misrepresented opioid. I think it was a Percocet that contained carfentanil. And that's the first I've seen it, but it's out there. It's not super common, but it's out there. Fentanyl, on the other hand, is so common that labs in Chicago and Massachusetts don't even bother reporting adulterated substances that contain fentanyl anymore unless they're like not an opioid at all, because it's in everything now. And can anyone think of why? Why do you think that fentanyl might end up in opioids versus non-opioids? Any thoughts here?
Because the effects are similar and it basically gives it more punch, whatever it's adulterating.
Okay, for opioids, yes. Why do you think fentanyl might be in non-opioid drugs? Like, why do you think that fentanyl is so prevalent in cocaine? Because yes, fentanyl is being found in quite a bit of cocaine right now. Why do you think that might be the case? Any guesses?
It's a white powder among other white powders that gets thrown in accidentally when you have a bunch of white powders in the same spot.
Yeah. So a big misconception about fentanyl being an adulterant of like coke or ketamine or MDMA or anything like that is people would be like, oh, well, a dealer would cut their shit with fentanyl to make it more addictive so that your client base keeps coming back, which seems like it would hold some water, except you would have to wonder why the fuck someone would put an incredibly powerful sedating opioid in a bag of cocaine and expect that their client wouldn't notice. And the answer is most likely accidental cross-contamination. It's real easy to have a lab that processes a lot of different substances where all it takes is you just like touch some with your hand and get it on another bag, and all of a sudden you have a potentially lethal dose of fentanyl in a bag by accident. So the leading theory is that this is usually not intentional because it really wouldn't make sense for it to be intentional, right? We see opioids being used in pop culture, especially in the form of Percocet and codeine all the time. And syrup is codeine or scissor or lean or whatever you want to call it. We'll come back to in a second. But hip hop really popularized this notion of like casual opioid use. And especially like in blues communities in the 60s, this was also a similar thing of like popularizing, becoming a community activity. There's a great Vice documentary on Florida rappers and lean. Super interesting. Now, when we're looking at the trafficking flow of these substances, we start out usually like fentanyl is primarily, I actually think that they may have recently passed some legislation against fentanyl coming out of China, but I'm not sure because believe it or not, fentanyl is really commonly used in any mix of substances that would be used to anesthetize you in surgery. It's a really common surgical tool. It's a very important surgical tool because it's so potent and it's so man-made. In China, you can pay $3,000 to $5,000 for the synthetic drugs and the machinery required to make them, transport it to Mexico, and cartels like the Sinaloa cartel, which is a massive Mexican cartel, possibly the most powerful and largest one right now, will transport that into the United States. And does anyone have any guesses for how much money this cartel can make from what started out as a $3,000 investment? How much money do you think they make? Guesses. From $3,000. Any guesses? I see $1 million. Any others? Too sleepy. I get it, bro. Okay, I give up. It's $1.5 million. Yeah. So that was a really good guess, Lindsay. That was a great guess. $1.5 million from a $3,000 investment. So we can kind of see now, possibly, why this might be an appealing industry to get into, especially given the notion that the vast majority of the locations in which these drugs are manufactured, packaged, processed, and smuggled are in incredible poverty. How many of you have been watching The Business of Drugs that's on Netflix right now? Anyone? No? Rip. Okay. So actually someone who's in this class sent it to me and was like, hey, my friend was a cameraman on this show, you should check it out. And I was like, oh, that's tight. So my housemates and I have been watching it. We've only gotten through the first 3 episodes, and I have a couple complaints, but generally speaking, it has a really good lens on how poverty contributes to the system. Let me make this clear, in case I haven't said it enough. Poverty is the single biggest root of the continuation of the war on drugs and the drug trade. Poverty and racism, those are the 2 things. Like, shift everything else out of your mind. Poverty and racism are what keep this going. You probably have heard the term pill mill at some point in the past, and in case you're not familiar with what it means, it's basically a clinic where you can go set up an appointment with a doctor and you have an unspoken agreement where you'll make a complaint and the doctor will prescribe you opioids. This is a patient-provider relationship where oftentimes the providers will receive kickbacks or bonuses, basically, from the pharmaceutical companies producing these opioids. A major example of this was the fentanyl sublingual strips Subsys, which we'll talk about in a later lecture when we talk about the pharmaceutical industry, where Subsys was manufactured by a guy who knowingly would encourage providers to prescribe it to people that didn't need it, thereby creating a cycle of patients that would just come back for increasing dosages of fentanyl. Now, here's what I'm sure many of you are most curious about. Correct me if I'm wrong, but I would imagine that this is like the big thing that a lot of you want to know the real facts on, is heroin. Obviously, this is, aside from meth and PCP, the #1 most controversial drug ever. And usually if you find out, oh, this person like smokes heroin or snorts heroin or injects heroin, that's an instant social identifier, instant. And it supersedes literally everything else about them. Am I wrong? If you meet someone and they're like, I smoke dope, everything else about them goes out the window immediately. It doesn't matter where they came from. It doesn't matter where their parents lived. It doesn't matter like what their background is. What matters is that they smoke dope. So let's crack this a little bit. A dose of heroin when you're injecting it is between 8 and 15 milligrams. This is, if you're looking at it in a capsule, like this much powder. It's a really small quantity and it's really easy to mess up, especially if you don't have access to a milligram scale, and milligram scales are not very accurate under 10 milligrams. It's hard to get this dose right. And for this reason, it's really easy, obviously, to overshoot it, sometimes to the point of it being lethal in your first go. If you're snorting it, it's going to be a much higher dosage because you need more of it to cross the blood-brain barrier, etc. If you're smoking it, you need a little bit less. And I think that this is kind of a good indicator of the different levels of substances needed to achieve the same level of high based on the route of administration. Like at the lowest, you have oral, and then there's boofing, approximately, and then there's snorting, and then there's smoking, and then there's injecting. And all these things have to do with how quickly this drug can hit your bloodstream, how easily it's absorbed from there. Tons of different names for heroin. Most frequently, it's called smack or dope. If you're buying black tar, it's called tar. If you're a cop, you call it chiva or horse. I don't know anyone that's done heroin that's called it chiva or horse, but maybe that's a regional thing. And if you're high on heroin, it's usually called nodding or being doped up. But there are some other terms for it that are, like, again, more regional. Usually heroin will come in a powdery kind of chunky form like this, and it's tan-ish rocks, and it can also look a little bit more like this. This is just different forms of the same thing. But then you can get into tar, and black tar is a totally different kind of heroin. It's the same general thing. It's heroin, right? But it's usually produced in Mexico, and it is like a sticky, oily rock, basically. That's a lot cheaper and easier to produce, and to my knowledge, also produces a more intense high, but has other risks that come with it, which you can probably imagine because look at the rocks. They are like covered in olive oil. And then there's actual vials of liquid heroin, it's called diamorphine, and you can get it prescribed, or like not like take home heroin, but like it is used in medicine. This is black tar. This is a big ass fucking block of black tar too. This is an ounce of black tar. And think about an ounce being 28 grams and 28 grams being 2,800 milligrams. Is that right? Oh my God. Please tell me that's right. No, that's 28,000 milligrams. I have a computer science degree, you guys. I can't do basic addition. It's so bad. So most of the time it has a very sticky kind of viscous texture. Now the problem that we see from this is that if you are attempting to shoot up black tar, this is a really, really high risk scenario for collapsed veins, because most of the time when people have skin problems from injecting something, like I've said before, it's not because of the drug itself, it's because of the contaminants in the drug or the contaminants on their equipment to inject the drug. This is a really important distinction to make, right? People that have IV drips of diamorphine or morphine or fentanyl don't get abscesses. Think about that, really. Like, it's a needle going into your vein. Why wouldn't you be at risk of abscesses? So when we see these things being like, if you do heroin, your veins are going to collapse, your arms are going to get fucked up, the reason for that is that people don't have safe injection practices. They don't have resources to do so. And then there's wound botulism. Sorry for the images, but you have to see them. This is basically when bacteria gets into your wound, it can cause like festering and your flesh disintegrates kind of deal. Again, a product of using contaminated resources. This should be something that's easily fixable by needle exchanges, right? Like we would be seeing a far lower rate of people coming into emergency rooms with gangrenous arms from injection if they had access to clean injection tools. Just imagine the amount of pain and money and labor and heartache that would be saved if people didn't have to come in the first place for these things. Do we really think that it would encourage them to use more if we had access to needle exchanges? And if you say yes, like I would understand why, but you should say so, even if you want to just message me privately in the chat and say I dissent, and we'll talk about it. Most of the time people start doing heroin by smoking it, I would say, before injecting it, because a lot of people feel as though injecting a drug is like the final stop. That's as far as you can go. And a lot of people really balk at injection, which is interesting because, truth be told, in some cases, there are certain drugs where it's actually quite a lot better for your body to inject them. The problem with injection is, again, it can induce such a more intense high that it's really easy to overdose when you're injecting something, and it's really easy to get a way more intense effect from the drug than you would otherwise want. By administering a drug in different ways, you can kind of control how intense it's going to be for yourself, and therefore kind of get a better feel for the amount of mental pull that you might have towards this substance. So injecting heroin in particular, it comes on in seconds. It's really fast, lasts for about 4 to 5 hours, right? If you snort it, it takes a little longer to come up. If you smoke it, it's like seconds as well to come up. So again, we'll see these patterns here and how routes of administration have slightly tiered levels of how long they last, how hard they hit, and how quickly they come on. So again, I can't reiterate this enough. We look at something like this and we see the effects of injecting an opioid. And most of what we see here is that the way that you do it is more important than the substance itself. So for instance, if you're crushing a pill, you can have collapsed veins because it's a chunky ass pill, right, that contains excipients and binders. If you're sharing needles, you're prone to bloodborne diseases. If you are using other kind of crushed pills, well, this one actually is just like due to heroin itself. Like sometimes opiates can lead to really serious respiratory problems, which we're seeing a rise of because of COVID-19 as well, right? And all kinds of other complications that come from the way that you do it. However, heroin itself also has inherent risks, obviously. Now, track marks are something that are really commonly seen in people that are regular routine users of injection drugs in general. And this is basically just like little scarring over where a person is injected. So oftentimes a parole officer or someone that's in a drug court kind of setup might come in and be inspected for track marks, even on a low key level, or someone in a doctor's office, if their doctor pulls their record, they might be like subtly checking this person for track marks to see if they've been injecting. And you can inject something pretty much anywhere. A lot of people that have gotten, because the classic thing is the arm, right? Like we see the tourniquet, because that makes your veins more pronounced. You smack it, it brings the vein to the surface. And the problem is that those veins often collapse after a period of time, and it prevents circulation. It can make you more prone to skin problems because your skin isn't getting enough nutrients and oxygen. But in the meantime, it also means that you have to get more creative with where you inject a substance. And this means that people often go from the arm to like the thigh or the back of the knee or the ankle, and then sometimes the neck as well. And you can inject things like right next to your jugular. You have major arteries right there. Is it a vein or an artery? Not a doctor, folks. But in any case, this is kind of the progression that we see because people lose veins that they can inject in, or those veins are damaged because they don't have proper equipment. And then there's abscesses and sepsis. And sepsis is a bacterial infection, right? Oh, I think it's bacterial. That can lead to systemic failure, effectively. Now, for those of you that are wondering what heroin is like, let's find out from someone who has actual experience with it. I think that's a really important and valuable thing, is to listen to the people that have done these drugs instead of reading all about it, especially from websites like drugabuse.gov. And like anytime you type in a question about a drug, the first 15 results will be from an addiction and rehab center. Those are not reliable sources for information about your drugs. Please look for alternate sources, and if you can't find any, hit me up.
Dangerous drug, it depends on the person. Some people would never try heroin, but they drink out of control. And for them, alcohol is more dangerous because they would never even use heroin in the first place. Also, it's based on genetic predisposition. I'm more of a tweaker. I react differently to stimulants and prefer them over downers. So meth is more dangerous for me. Heroin is the most dangerous downer that I ever experienced because I loved it, even though I'm not a downer person. Absolutely loved heroin. My second favorite drug, and I didn't use it for very long, which is crazy. I used it for 4 months. And the reason I didn't use it for very long is because and I talked about this in another video, is it was never enough until I was overdosing. Like heroin has a weird way, and I always knew it's dangerous and you can overdose, and I would prepare my dosage and go into it knowing I would actually test the purity of it by doing a very small amount, saying, all right, this is what this feels like. 3 of these should be okay. But whenever I got 3 of those and got what would be like a heavy dose, I always wanted more. And it's weird with heroin is it makes everything less important, even your own life. And the only thing that's important is reaching a certain level where you're content with how high you are or how, out there you are. And for me, I was never content until I was basically on the edge of death. Like I was nodding out, barely able to breathe. Then I loved it. I fucking loved it. What was the experience of it like when I was at that near death state? Heroin is fucking, I want to say it's not psychedelic and it's not a psychotic, but it's a visionary substance, which was so weird because nobody ever told me that. Like going into heroin, I thought it was just something that made you really relaxed. And when people are nodding out, I thought they were just kind of like falling asleep or feeling really chill. But you actually, when you're nodding out, especially on heroin, more so than with Oxycontin or any of the other opiates, I would go into like visionary states and like see things that made perfect fucking sense to me. Like a fucking, like I'd be like in Egypt on like some like one of those Egyptian buildings with a bunch of mimes that were morphing, and then they gave me some secret to reality and it made perfect sense. And then I come out of the nod and I would forget it. Like it made perfect sense. I knew the secret to life. I knew everything. These mimes told me. And then I'd nod out and I forgot. I'd be like, God damn it, I forgot. And then I nod back into another like kind of like dreaming, waking consciousness state where you're like dreaming awake, but the dreams are like really bizarre. But at the same time, you love them. You feel like so at peace with everything. Like it's the most peaceful feeling in the world, the most relaxing feeling in the world that I've ever encountered. And that's at like a high overdose state that I enjoyed where I started liking heroin. And that's my addictive personality. I'm a professional. I was a professional addict. Everything I did to the extreme.
So another thing that he mentions in this video is the sensation of being, I should not have just put chocolate in my mouth, is the sensation of being wrapped in a warm blanket, drinking a cup of tea, reading a book on a perfect rainy day with a cat on your lap. Like the most perfect sense of contentedness, not necessarily euphoria, but contentedness. Now, I'm sure that many of you might be wondering, actually, I'll come back to this question. So through time, using heroin frequently can damage the white matter in your brain. And the white matter can be kind of thought of as like connective, essentially. It's like the things in your brain that help your brain communicate with itself. And through time, this can get eroded. Your heart valves can be damaged as well through time from using opioids, particularly heroin, and your lungs. So if you are a chronic user of opioids, particularly heroin, you may be at higher risk of developing pneumonia or other complications like bronchitis because of a mechanism that I don't understand. I'm not an expert on opioids. So just to reiterate something about the relative difference between oxy and heroin and fentanyl. Here is oxycodone. Here's morphine, right? If this is the relative strength of these substances. Here's morphine down at the bottom, and then more potent than that is oxy. And then you have heroin, which is a couple times more potent than morphine and oxy. And then you have fentanyl, which really starts to get into big boy territory. It's about, it's fentanyl that's 100 times more powerful than morphine. And then you have carfentanil, which is just off the charts, right? Like off the charts. And I hope that this really puts in perspective just how powerful fentanyl is, but also how powerful opioids can be in the first place. Now, before we go into this one, I have a question. Knowing these things about heroin, and like, let's be real, everyone knows heroin's reputation. Why do people use it?
Because they've gotten addicted to other opioids.
Okay. I'm not going to say any thoughts on any of these until a couple of opinions have been collected. I'm just wondering what you guys think. Like, I'm really curious what you guys think.
Is the high relatively cheap compared with other drugs?
It depends on the quality of it. I'm actually not sure. That's a really good question.
Chronic pain issues.
Chronic pain?
The consequences of doing the drug are worth it to experience the high if they, the alternative is going sober and their life still sucking.
Hmm. Hmm.
Grief.
Sorry?
Grief.
Grief. Ooh, grief. That's a good one.
Escape, and then also, if you've done everything else, you want to go higher.
Hmm.
Sometimes you just want to feel good for a change.
Yeah. These are really interesting opinions and very insightful, all of them. So something that I think is a really common reason for people to use something like heroin for the first time, because that's what I'm really looking at right now, is why would you use it for the first time, right? Like I said, everyone knows heroin's reputation. And oftentimes the answer is everyone wants to know. The privilege of knowing, the privilege of having knowledge is massive and under-recognized. Having this thing that is like the magnum opus of drug use, like it is your ultimate forbidden fruit, basically. People that go into a heroin experience pretty much every time go into it with the mentality of, I'm just dabbling. I know how to get my feet wet without submerging myself. Like, I know how to control my habits. I have a plan in place. It's cool. And the thing about drugs is that we don't hear about the people who succeed, right? We hear about the people who fail. So it's really hard to know from a quantitative perspective who succeeds at doing so. From a qualitative perspective, it's often unsuccessful. Heroin is one of those substances where the power, sorry, I just keep swallowing air. The power of knowing becomes really enticing, especially for people that are experienced drug users in other realms. And I'm not going to say a hard and fast rule of like, if you do heroin, you are going to go down a rabbit hole. However, I will say that the likelihood of going down a rabbit hole with heroin is a lot higher if you go into it with the expectation that you can wrangle this. Sometimes it's not about you. Swallow my air all the time. Sometimes it's not about what you want and how you feel. Sometimes it is a biochemical reaction. Just want to put that out there. If anyone has further thoughts or questions on that, we should talk about it. So the concept of addiction and dependence, right, is kind of wrapped up in this thing that we refer to as a substance use disorder. Interesting comment. I had to take opioids for the first time for a week after surgery last year. I was zombied out, hated it, asked friends in a group chat, why the hell does anyone do this for fun? One friend answered with, they don't do it for fun. They do it because their soul hurts. Wow. That is, I mean, a really, again, interesting thought. I would argue that it's not always that way, though. I would argue that a lot of the time it is simply curiosity, and a lot of the time it is also a lack of understanding and a lack of education. And in some cases, it's a hereditary thing too. In some cases, it's like an environmental thing. But that is a really interesting anecdote. Thank you for sharing that. So a substance use disorder is usually defined as having multiple characteristics of indicating that someone has a problem with a drug. This drug is negatively impacting their life. And this is important to make as a distinction because casual recreational drug use is clearly possible. It's very possible. And it usually is what happens, frankly, because again, there are like a billion people at a time using drugs, and we only hear about the ones that have difficulties with drugs. Let's be honest. However, it's important to not understate the risks of certain substances, including opioids. Like, they are highly, highly risky drugs. So dependence comes in the form of having physical withdrawal symptoms and cravings. Like, your body is not functioning as it should without this substance. Or in the case of psychological dependence, your mental processes are not functioning as they should without this substance. Tolerance is when you need more of it in order to achieve the desired effect. And then addiction is extraordinary mental preoccupation with this substance. And this is the thing with heroin that gets kind of messy, because the physical dependence aspect of it frequently becomes the most prominent part of the drug experience for people that are chronic high dose users. Like, that is why the term dope sick is so potent, is because for many people, if you come down off of your hit, you only have a couple of hours before you could get really sick if you don't get another one. And that is a severe physical dependence, and it's extraordinarily easy to develop one. Does anyone know the other category of drugs where developing a physical dependence on them is actually really, really common, extremely dangerous, and not talked about? Pop quiz.
Alcohol.
Alcohol? That is true. That is true. But I'm thinking of actually a different, like a category within depressants. Think pop culture. Xanax. What category is Xanax part of?
Benzos.
Exactly. Did you guys know that there are only 2 kinds of drugs whose withdrawals can kill you? Benzos, and what else?
That one's alcohol, I'm pretty sure.
Alcohol. Benzos and alcohol. The withdrawals from opioids are extremely unlikely to kill you, but benzos very easily can. Funny, right? Just don't talk about it. Now, in terms of the relative popularity of opioids, heroin is like pretty consistently relatively popular, but we actually see that prescription opioids are among the most popular substances in terms of opioids that are used specifically to get high. Like, it's not actually heroin that's the big honcho here. And granted, this is older information, so don't take this graph as gospel. But it's funny, right? Like, we really do think of heroin as being the #1 causation of the opioid crisis, but it's just not. Like, it's not nearly as commonly used as prescription drugs. Like, oxy is one of the #1 substances that we see tested on drugs data, just like oxycodone, Percocet, OxyContin. So a lot of the time, the problems that we see arising from this, not 100% of the time, but a lot of the time, even doctors are not adequately trained to understand what can happen as a result of prescription opioids. And because of this, sometimes people will have a shoulder surgery or something like that, and they'll be sent home with their oxy or whatever it is, and they'll be taking it as directed by their prescriber, and they'll stop taking it, and they'll be like, shit, I feel awful right now. Like, I can't take my kids to school right now because I feel really goddamn sick. And this can lead to people that are just like completely by accident dependent on opioids, like really totally accidental. And while I would say that this is not the leading cause of the opioid crisis, it is certainly a massive contributor to it. A lot of the time, people will not be able to afford to get a continuous prescription of opioids once they've already become dependent on them, or they just won't be able to access them anymore because their provider will prescribe them a dose that leads to physical dependence, sometimes completely inadvertently, or sometimes just like by virtue of how that drug works. And then that person will need to continuously receive opioids because they can't function without them anymore. That's expensive. Sometimes it's no longer an option. What do you do in that point when you need to continue surviving? And the answer is either switch your route of administration, start smoking it because it gets you higher, or not even higher necessarily, it gives you a more potent experience, or start seeking other avenues to get your opioids so that you don't feel sick, so that you can function, right? And that's what we're really seeing right now, and we've been seeing for a while, is that people have to get creative in order to continue in the event of opioids as a prescription causing this process. So the withdrawal process of this, usually within 6 to 12 hours of a person's last dose of opioids, the withdrawal will start, and we're going to see this with most withdrawals except benzos, which are a totally different animal. Most withdrawals, the peak, the worst part will be 1 to 3 days afterwards, and then for a week thereafter, it will continue tapering off. But the real issue here is not necessarily this acute withdrawal period, it's the entire period of time thereafter, for people in particular that have a mental preoccupation with this drug, right? It's one thing to get your body off of it, it's another thing to get your mind off of it. So we see some systems that are put in place to support people during this 1 week where they're tapering and subsiding, but then afterwards there's no support. And this is why we see such a high relapse rate, because if you take someone who, for instance, is impoverished and having a bad time. Let's take one case example, for instance, of someone that is simply having a really hard time. And they've heard that heroin makes things feel like okay for a while. Start doing heroin for a bit, still impoverished, still working a 9 to 5, get laid off from this 9 to 5 because they show up nodding, can't function if they're not. And then they manage to go through the detox process, they get clean again, and then they're in the same exact situation. But now they might have drug court records or probation records or like a criminal history from having been caught with possession. This cycle will just continue inevitably. Why the hell would this person stop using heroin entirely if this is one of the few things that gives them relief from an otherwise impoverished and extraordinarily painful situation in their life? Why? There's no point.
When people say they have a near-death experience, they see their whole life flashing before them. It's kind of like that constantly, with all the bad stuff standing out. The first time I did an actual full-on cold turkey, it's 5 days of sheer hell. I was horrendously sick, crawling to the toilet every half an hour with green fluid flying out both ends simultaneously. Sweat went through 2 thick floor cushions into the carpet. It's really grim. But they didn't last very long because I didn't really want to stop taking it. I wasn't ready. And then things went crazy for about 5 years. So my last hit, it felt kind of like splitting up with a girlfriend that you loved a lot, but who was really bad for you. It felt hard to say goodbye, but I knew that I had to do it.
So a really frequent descriptor of the, a really frequent descriptor of the experience of detoxing or the experience of giving up a substance that you are addicted to is breaking up with your soulmate. And for those of you that have done that, or for those of you that have lost someone who is massively important to you in your life, it is very literally, from a chemical perspective, a similar response in your mind of losing, like someone dying that you love and care about, which obviously is extraordinarily difficult because doing that with intention is so hard. And so it's really like, I hope that this gives the people in here a little bit of perspective and a little bit of empathy for the experience of needing to voluntarily choose to stop doing a drug that you are addicted to. It's like intentionally like walking away from the person that you love most in your life and knowing that you'll never see them again. It's really fucking hard. So treat those that are going through this process with kindness, because what's the goal? You know, what is the goal here? Is the goal to make them feel guilt and shame for this experience that they're going through? Because I guarantee that that is not going to help them sustain this thing that they're trying to do. Shantaram, yes, I'm actually currently reading Shantaram. Or actually, I stopped a while ago. How many of you have seen Trainspotting? Okay, a couple. So Trainspotting gives this very dramatized description of the process of preparing for quitting heroin. It's also a wonderful film with young Ewan McGregor.
Relinquishing junk, stage 1, preparation. For this you will need 1 room which you will not leave, soothing music, tomato soup, 10 tins of, mushroom soup, 8 tins of, for consumption cold, Ice cream, vanilla, 1 large tub of, magnesia, milk of, 1 bottle, paracetamol, mouthwash, vitamins, mineral water, Lucasade, 1 mattress, 1 bucket for urine, 1 for feces, and 1 for vomiters, 1 television, and 1 bottle of Valium, which I've already procured from my mother, who is, in her own domestic and socially acceptable way, also a drug addict. Now I'm ready. All I need is 1 final hit to soothe the pain while Valium takes effect.
Okay, so treatment for opioids. This is not something that we're going to go super far into, honestly, because there's so much to cover, and this is a really complex topic. But the most accepted current medical treatment for opioid recovery for people that have been struggling with opioids is replacement therapy, or ORT. And this usually comes in the form of dolophine, which is methadone, or Suboxone, which is buprenorphine. And both of these have different kind of chemical profiles, but the whole idea here is that you swap out the opioid of choice that you would be using with a different opioid with a slightly different effects profile that makes it easier to go about your life and easier to taper. Less of the impeding effects, less of the high effects, and it satisfies your brain's need for this additional opioid presence. And this is really this kind of replacement therapy is the only way that millions and millions of people survive on a daily basis every day. When we're looking at overdose, this is a really important thing to know, because this concept of overdose is applicable to everything for the most part. Obviously, the most obvious part is that your dose changes. It's different than what you usually do, and your body can't accept or tolerate it, so your system is overwhelmed, and whatever the effect of the drug is too much and your system shuts down. Then there's tolerance, which is when if you have a reduction in tolerance, maybe unexpectedly, and you try and do your normal dose, it's going to impact you a lot more. And these might seem really obvious, but again, just to reiterate, the number one biggest danger and the real threat of overdosing with opioids is that your heart will stop because your blood pressure is so low, and your breathing will be really depressed. If you suspect an opioid overdose, your ass had better administer CPR right away. If you don't know how to do it, it is so worth knowing how to do. Seriously, you could save someone's life, actually, even if it's someone that you don't know. But here's something that you might not know. And here's something that is actually a really huge contributor to overdoses, especially with opioids. If you're in a familiar environment, your brain knows to expect what's coming. If you are always doing the same drug in the same place, your body compensates in preparation for what's about to happen. So if it's okay, I recognize this room, I recognize this spoon, whatever, I know that my blood pressure and heart rate are about to drop, you're actually compensating in advance because your blood pressure and heart rate will go up in preparation for this, right? If you're doing the same dose of the same drug in a new environment, your body will be less prepared to handle it. And this is actually a huge, like I said, a huge reason that people overdose on things. They're like, I don't understand. I took my normal dose from the same guy, which means nothing. You should always test it. But I don't understand. I took the same dose. And they're in a new place. And that's the entire reason that they overdosed. So if someone is doing acid, for instance, at home for the first time instead of at a festival where they've always done it, or vice versa, you might find that your experience is a lot more intense, which is kind of interesting, right? If you're always tripping in the same place, it's the same kind of idea. So a lot of people at Burning Man, for instance, are like, I don't even feel acid anymore because they just always do it at Burning Man. And the reason is that there's a compensating effect happening. Now, naloxone is something that at this time in history, everyone needs to know about, which sucks, but we all need to know about it. The gist of Narcan, of naloxone, for those of you that are not familiar with it, is that it comes in a nasal spray, and it basically knocks the opioids out of the receptors. It pries them out like a flathead screwdriver and fits itself in instead. And this is really important because it reverses the effects of an overdose, kind of temporarily. Oftentimes, if someone fully comes out of an overdose, they're not going to go back into it. But if their dose was high enough, they might. So you should always call 911. Always call 911. It can be administered in a shot intramuscularly, or you just jab it into a leg and push it. But usually you can get it as nasal spray. And you can pick this up at, I think, pretty much every major pharmacy, which is a big deal right now. Now, when we're talking about the opioid crisis, right, we need to be looking at housing insecurity, at bloodborne diseases, at poverty, like all these things that I've just reiterated over and over and over again. And I know that I must sound like a broken record, but it's because still to this day, people attribute the opioid crisis to a mass moral failing. And this is the biggest thing that we do to discredit the humanity of the people that are impacted by this and to not give accountability to the people that are perpetuating this, which is everyone that contributes to an unequal and impoverishing and racist fucking system that disproportionately targets people of color and the poor in the United States. That is the reason for the opioid crisis. That is the reason for the war on drugs. That is the reason for our incarceration crisis. That is the reason. Please don't lose sight of this. Please do not fall into the trap of attributing these problems related to drugs to the moral failings of the people that use them. Oh yeah, there are animations on this slide. Overdose, disease, economic failings. And it's a vicious cycle, right? You start out with overdose, which leads to hospitalization, which leads to incurred medical costs, which leads to decreased access to high quality product, which leads to higher likelihood of contamination, which leads to higher likelihood of complications with your health, abscesses, sepsis, gangrene, all kinds of shit, even more medical bills, even more debt, and being administered opioids while in a hospital setting. All of these things contribute to a cycle. And until we identify that there is a cycle involved here and it's not an isolated incident and there is a place that we need to stick a wedge in and change things, it's going to keep happening, period. Obviously, these numbers keep climbing every single year, and I know we only have a minute left, so I'm going to try and hustle. These numbers keep climbing, right? We're seeing a massive spike in the incidence of fentanyl, which is why fentanyl strip testing is becoming more important than ever, including and especially with your white powders at home. And it's not a perfect test system, but it's what we have right now. Now, currently, we're also seeing just like a rise in general with other substances that are causing overdose deaths or involved in overdose deaths. And oftentimes these deaths are the product of mixing different drugs. But we're seeing increases across the board pretty much, especially in benzos, including in meth and cocaine. We need to be asking ourselves, if we've been implementing these policies with the war on drugs for so many decades, if we have so much legislature in place to punish people that use drugs, and if we have such a national spotlight on the dangers of overdose from synthetic opioids and opioids in general, how the fuck is it possible for us to be failing this hard at protecting the people that are impacted by this legislation? How the hell has this gone so sideways? And how are we not holding people responsible who are doing this to our system in the first place? That's all for this week.